Committee Room 29, sound. 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 Committee Room 29, Committee Room 29, Sound. Committee Room 29, Sound. Committee Room 29, Sound. Committee Room 29, Sound. Committee Room 29, Sound.
Broadcaster Parliament buildings and online, and that you're all welcome to use mobile devices as long as they're muted and in airplane mode. I haven't had any apologies. As I said, everyone is here, and Alan Robinson is joining by video conference. So if I can refer members then for the it's a single item agenda to page 4 in your pack, just as we wait for the Minister and the officials then. Well, very welcome, and thank you for agreeing to meet with the committee today at such short notice. We do appreciate this, a very, very busy time for everybody, but I hope that you also recognise why we wanted to meet. I suppose I want to say from the outset, the purpose of the meeting isn't to attack or be critical of anyone, and I know everyone is trying their very best, but I think we need to give the public confidence. And we need to understand where the key issues are and what can be done and what is being done in the here and now, and obviously to inform future planning. So we do really appreciate you coming today, Minister, and to the officials as well for your time. So in attendance we have Mike Nesbitt, Minister of Health, Tracy McCaig, the Chief Operating Officer for Strategic Planning and Performance Group, Jennifer Welch, Chief Executive, Northern Health and Social Care Trust, and Dr Joanne McLean, Director of Public Health for the Public Health Agency. So you're all very welcome. And just to remind members and witnesses that we have approximately 1 hour and 30 minutes today. I know members will have lots of questions and points they wish to raise, but if we can all be respectful of other members who also want to get in, so we can give everyone time. And if there's time at the end and we need to come back on anything, I will be flexible if people can work through that as we go along. The session will be covered by Hansard, so just to open, Minister, if you wish to make some remarks, and then we'll open up to the members. Thank you.
Well, thank you, Chair, and I do welcome your invitation to join you and to work collaboratively on this issue. You'll be aware I'm keen the committee assist and advise as per the Northern Ireland Act. I'd like to begin by paying tribute to all health and social care staff and the work they've carried out over this Christmas period. Many haven't had an opportunity for a break. Many others take that break for granted at this time of year. And I'm just very grateful to them, and I understand we cannot run the health and social care service forever on goodwill. It has to be, by definition, finite. So I've been looking for levers short term, but as you know, I'm also offering a blank page for next year. But I think we need to be honest and realise there's there are already available slate of immediate actions. If they were available, they would have been implemented a long time ago. What's happening, however, and where resources allow, is the implementation of the short, medium and longer term recommendations following the previous GIRFT, or Getting Right First Time, review of urgent and emergency care. Some of the measures we were able to introduce were the introduction of Pharmacy First sore throat services across all pharmacies in Northern Ireland. These started from the 1st of December last for everybody aged 5 and over. Then there was the rollout of vaccination programmes for COVID-19 and influenza, along with an additional RSV vaccine. We had the provision of an extra 3.4 million. That was to help GP services meet additional winter demand, with a further 4.6 million being provided to assist the delivery of proactive support and care to those in nursing and in residential homes. There was also the provision of Phone First services across all geographic trusts for urgent and unscheduled care. Over 160,000 people accessed the Phone First and urgent care services last year, 85% of whom completed their care without needing to attend an ED. An additional investment of 5 million has been allocated to trusts for 24-25 to enhance independent sector provision of care packages for the over 65s. And to make best use of available home care capacity, trusts have also been provided with £697,000 in recurrent funding to establish early review teams to help release capacity by identifying if needs have reduced in the period since returning home. Chair, I want to emphasise this is not just a Northern Ireland specific problem. Over the weekend past, a Liverpool Health Trust has declared a critical incident. 2 others have similarly declared critical incidents, Plymouth and Hampshire. I'm not saying that to minimise the importance of what is happening here, but it's an illustration that the pressures are both serious and nationwide. Across Northern Ireland, we've seen 3.6 times as many patients hospitalised with flu this winter compared to last year. I'm not going to insult members by asking when they last visited an ED. I don't think any of us can compete with Mr. Donnelly on that front. But I have had several planned at short notice visits. 2 today to Altnagelvin, which is the oldest ED, and this afternoon I was in the Ulster, which is the newest, and there are common themes here. Patients, I think, arrive with a reasonable expectation that they won't have to surrender their dignity and their privacy, but that is often the case in these crisis times. And the staff are suffering moral injury. They did not sign up to deliver a service in this way. But Chair, emergency department pressures are a symptom and not the cause, and that's not my assessment. It's the view of the Royal College of Nursing, the Royal College of Emergency Medicine, Trust Emergency Consultants, ED Managers, ED Directors. So it's a whole system challenge that we face, involving who comes through the front door and then where they go. Is it ED? Is it ambulatory units, such as urgent care, respiratory or cardiac units? Is it about hospital at home? Is it about access to GPs? Is it about Phone First? And of course, it's all of these things. And it's also about getting people out the back door. And we know that domiciliary and care home availability, capacity, is a huge challenge. We also need to increase the workforce, and we need to increase pay. As I said, I'm offering a blank page to look ahead to the winter of 2025. And the question for you, Chair, is what role does the committee want to play? Do you want to be positive? Because it appears to me certain MLAs engage only after the fact, when the opportunity arises to criticise without alternatives. When I published the winter plan on the 6th of November last, it had been planned since springtime, since March of 2024, and it was very clear it expected a very difficult winter, and that the plan would not eliminate the pressures, but at best would mitigate them. We know people get sicker for longer over the winter months, and this adds to the 365 pressures on the EDs and the whole HSC system. Winter pressures are real, but they shouldn't take our focus away from the fact ED pressures are now daily. And if anybody around this table thinks there is an easy solution, a quick solution, or a cheap solution, I'm afraid they are mistaken. HSC, of course, as I say, needs buildings, it needs equipment, it needs medicine, but it needs staff. And without the staff, everything else is meaningless. And I think my single most important contribution to winter pressures was to avoid immediate industrial action by staff. And on that front, Chair, I need all your parties to help with the relatively small gap in delivering pay parity that I need to close. And I invite you to encourage your executive colleagues to support that initiative in January monitoring. I've heard some members of this committee say this is not about money and that health gets over 50% of the entire executive budget. I would suggest respectfully the percentage is a red herring. This should be about assessed need. It is, of course, also about efficiency and productivity, But no amount of efficiency or productivity will close the gap between demand and capacity. We know that getting back into Stormont in February made an argument about the block grant, that it shouldn't be based on accrued headcount, but on assessed need, and on that basis, it moved from 100% of English spending to 124%. So it's not about headcount, it is about need. Without the resources to change, we cannot change. Without change, frustration will continue for patients, for service users, for staff, and via the media, the population at large. Without resources, Chair, we will fail, and we will fail collectively, and that surely is not an option. In conclusion, let me say demands for easy, immediate answers are understandable but misguided. I have set out my 3-year plan, and in it are the key actions I believe will improve health and social care delivery. I'm clear we need to invest in community and in primary care. One aspect is that we need to improve availability of social care. And as you know, my predecessor invested 70 million in social care this year, and I'm planning to go further and ensure all social care workers receive the real living wage at an estimated additional cost of some £50 million. That will help stabilise the system. Hopefully it would also attract new people to work in it. In short, I intend to be the health minister that brings to an end minimum wage employment for social care workers. And the committee can help by backing my case for additional funding to meet this cost. In primary care, I want to invest more in multidisciplinary teams, MDTs. That will help by allowing more people to be treated in the community. It will reduce future hospital attendance. And in terms of winter pressures, it will free up GPs to see more patients with flu symptoms and help address access issues. The committee can help in this respect by backing my bid to the Transformation Fund for MDTs. These are practical examples of steps that need to be started now to take effect in the coming months. And Chair, I said I began by saying I was looking for levers to alleviate the current pressures. Just before I left the department to come here, I was able to sign off on one such lever. Flu vaccines will now be available to the over 50s, i.e. the age group 50 to 64. That is a new development. Having prioritised those most at risk and healthcare workers, I'm now in a position to widen the reach of the flu vaccination programme.
Thank you, Minister. And I think the vast majority of your opening remarks, there's very few of us around this table would disagree with. I suppose just in terms of the funding issue, and we have said on numerous occasions around health being prioritised, we all know that there's not enough money in the overall budget for every department and to go around every department. However, I do think that your ask in terms of the next monitoring round, there has been a clear prioritisation by executive colleagues to give where can be given. So I would hope that that gap will be closed also in the next couple of weeks. Minister, I suppose you have said that you welcome any suggestions, any solutions, and like yourself, I've spoken to many frontline workers, representative bodies over the last week in particular. This morning just I met with GPs in my own constituency as well, who are very keen to be able to support in any way they can. And I suppose my first question then is around the vast majority of the patients who we are seeing who are sitting in corridors in EDs are very vulnerable, elderly, frail people, many with dementia. And as you will know, and your colleagues around the table will know, that those prolonged waits in very undignified, inadequate environments, and this isn't being critical of staff or anyone else in relation to that, but that further deteriorates then their overall health. And people who have gone in with a physical health need may then be in a very short space of time have a deterioration in their mental health and their cognitive ability, which has further implications for their stay in hospital and what their needs are, their assessed needs are for discharge. So some of the issues that have been brought to my attention and suggestions are looking at how we can keep people from actually having to go to hospital in the first place. You will be very aware of the acute care at home service that is predominantly in the Southern Trust area. It works extremely well. I was speaking to a lady this morning whose mother accessed it in recent weeks, and she could not speak highly enough. I suppose my question is firstly in relation to that. Is there more that we can do to enhance that service, to create an extension of the service? I know it's not existing in all areas, and to look at that, the potential of that provision on 7 days a week, because from my experience working with older people as well, that is something I think would really help to alleviate pressure in the here and now, but also would have really good impacts for patient outcomes. So I suppose that's my first question. And in addition to that, I suppose that primary care, you mentioned about the investment in primary care, and I know that's a long-term goal as well. But I do think that our GP practices, community pharmacy, the sore throat service, I think is due to end the end of this month. Is there scope to extend some of those community care elements, primary care elements that would definitely help to alleviate what we're seeing in our emergency departments?
Look, there's a lot to unpack there, Chair, and to start where you started. I mean, I've visited today, as I said, I've been in 2 EDs, Altnagelvin and Ulster. And the common theme among the staff is that when patients are coming in, because they're spending much longer than they should in an ED department, they are suffering harm, both physical and mental. And of course, that by definition is bad for them. But it also makes the challenge of offering them cures more difficult because the problem becomes more profound. And of course that impacts on what I was talking about in terms of the moral injury to staff who are seeing this as they go about their shifts. And it really hurts. And I get that. And to see people sitting, as I did this morning at Altnagelvin, a man has been in the same chair for 4 days, since Friday. 4 days. Where's the dignity? Where's the privacy? Because that chair's in the corridor. There were 3 small plastic chairs side by side with a set of blankets and a pillow on it. The patient had obviously gone off to do something. At Altnagelvin, for example, the wash facilities, I think there are 2 toilets in the ED. There are no washing facilities for people who are in there for day after day after day. So it needs I know I'm digressing a bit here, but we need a new ED at Altnagelvin, and they will get one, but it'll probably be 5 years. In terms of things like that, acute care at home, hospital at home, this is the future. I believe that actually in terms of cost effectiveness, this is a better financial proposition than having people in hospital, in an acute hospital overnight. But more importantly, I think it delivers better outcomes. So yes, I'm extremely keen this year to talk about how we expand those services. And yeah, they're not everywhere, but I see Jennifer's nodding and she may wish to add to that comment. But we have to look at that. Phone first. I think about 160,000 people have used Phone First in the last year. And it's resulted in maybe a quarter of those phone calls resulting in people being told to go to ED. So there are things happening and there is reform underway. But Jennifer, you may want to come.
Yes, and thank you for the opportunity to be here today and to discuss these things with you. I think acute care at home is absolutely one of the key things that we need to take forward. And you've mentioned the Southern Trust there, and it is probably the service that is the most well developed and advanced, and we hear great things about it. I would like to have such a service in my area. So mine is the one trust where currently we do not have an acute care at home service. We have elements of it, but that's certainly an area that we would be very, very keen to expand into. Because we don't have that, we have invested in other ways. So we have put a lot of our money into our ambulatory care work stream. So we have a very comprehensive ambulatory care service at both Antrim and Causeway. And GPs have direct access into that, as does the Northern Ireland Ambulance Service. So it's another way of keeping people out of the emergency department and having that ambulatory process. But there's still more that we believe that we could do with an acute care at home service.
And I suppose my question in relation to acute care at home was more to now. I mean, is there anything we can be doing to enhance that service now? I know, Minister, you've said about into the future, and ideally we would like to see that in place across the board on a permanent basis. But is there any levers, scope within the system at the minute that we could expand that now to try and support what we're seeing in our hospitals?
Well, I don't think in a particularly significant or meaningful way, because capacity is now pretty much at full stretch. And you've got to remember that in terms of this flu influenza, that health and social care workers obviously are not immune from it.
Yeah.
So there are huge pressures in terms of staff. Before I bring Tracy in, just on you asked about the sore throat service in terms of Pharmacy First. It will not end at the end of January. It will be extended to the end of March.
Okay, that's positive then. Thank you.
Yes, we have been having discussions from our team within the Strategic Plan Performance Group with our trust to see what can be done. I think, as Minister said, the ability for us to do something today, this month, is absolutely constrained. However, I have been talking with Chief Executives about what we can do in a slightly longer term. We would have the ambition to have more acute care at home, hospital at home. There's lots of different versions of it. Southern, you've mentioned, absolutely has been running much longer than others, and there's a lot to learn from the model, but we'd like to extend and we'd like more, and we'd like it over a 7-day week. All of that will require investment and reshape in services, but absolutely the ambition is there to take it forward. Unlikely in the coming weeks, it's not going to help us with what we have at the minute, unfortunately.
I think you were with me in the Daisy Hill when we met a service user of the acute care.
We met afterwards, I think.
Oh, right.
Yeah, but I know you had seen them.
If you could bottle them, it would be fantastic.
Yeah.
I mean, he's such a fan.
Yeah,
of
no,
what
it
it's
is.
achieving.
I mean, and I think, as you've said, it's a real solution to dealing with. I mean, for the vast majority, particularly for elderly patients, they are much better being kept in their own surroundings. I can't imagine what it is like for for any patient, but at least not an elderly patient with maybe some level of dementia, who is sitting in a corridor for 3-4 days with lights on 24 hours, staff walking up and down, patients coming up and down, visitors coming in and out, no privacy, no dignity, all sharing the one bathroom, having all your meals, everything. I cannot imagine what that must be like for someone. And then I heard of a patient in the last day or so who went in relatively fit and healthy, no cognitive issues, an older man with a physical ailment, and has been in a corridor for 3-4 days and is now very confused. So that's the level of deterioration and how rapid that can happen. And you know, so it's just to highlight that. So I suppose my approach to that is looking at how can we ensure that people don't even need, there's people who could be looked after elsewhere in a much better way, and how do we do that? And if anything, if there was any flexibility to enhance that, whether it's speaking to staff on the ground to see is there scope to move staff around into acute care at home teams or something, I think all of that needs to be explored where possible.
Yeah, and when I talk about levers, I'm talking about, can we just nudge something here or there, such as the vaccinations for the 50 to 64-year-olds. But you're right, I mean, people get confused, and then there are falls within ED departments, so then there's another issue that needs addressed. And could you imagine if you're in the ED because you've got a mental health issue and it's a severe one, the lights, the noise, the activity, so it's not good for you.
I suppose that leads nicely into my next point then, and that is, I suppose that it's from my understanding is the patient flow through the hospital from the front door through into admission and then obviously for discharge for those that have been admitted. I think, you know, we've heard very clearly that people are in ED for long periods of time because then they have nowhere else to go. And I have been speaking to staff, and there have been queries raised about potential ward space in some of the hospitals. I know certainly in the Belfast Trust area there may be ward space there or beds. Is that something that we can utilise? And if not, why not? Is that a staffing issue? Or what is the scope around that? And I suppose secondly, in EDs then for triaging, some of the suggestions put forward to me was the potential to have, if this isn't happening, and that's why I want to ask the questions, to have a senior registrar consultant on duty from maybe 7 in the morning to 9 o'clock at night who could assess patients throughout that period, because I think after 9 o'clock you're not going to be discharging anyone, particularly older people. And likewise, is there any scope to bring GPs into EDs where possible? And that's not to dilute the service on the ground, but I think there has been a pilot, I think potentially in the Northern Trust, Jennifer, was it? There was a pilot in the past where the GPs could even have access to direct admission as well.
So that's our direct assessment unit, the ambulatory pathways that I was mentioning. So yes, the GPs have direct access to those. So they don't have to send the patient to ED. They can phone in, have a conversation with the consultant in charge and refer directly into the direct assessment.
And is that still ongoing then across all EDs?
I think probably ours is the most developed in terms of Antrim, and then secondly in Causeway. Most people in the trust areas have some element of ambulatory services, but I suppose where we don't have acute care at home, we have the very well developed direct assessment unit, and it's slightly different in other trust areas.
Okay, so I suppose maybe those kind of questions around having a registrar or consultant on duty, is that in place, and if not, is it something could be expanded across those that key time period? And then about the extra bed spaces, or any, are we looking at any scope to try and increase that, to try and move people out of EDs where they do need to be admitted?
Okay, so at present there are 351 undesignated beds in use, and that's not enough. But then you get down to a question of space, and particularly a question of staffing of the workforce to look after them. Well, I think there are 288 patients in hospital with flu as of yesterday. And as of yesterday, there were 516 patients who were deemed to be medically fit and awaiting discharge, which is a lot more than the number of patients who are in ED waiting for a bed. So that's where the problem is with the flow. In terms of some of the things that perhaps have been in the media in recent days, it might be worth, Chair, just addressing those first off. I'll ask Jennifer about White Abbey in a second. In terms of the military, because the problem is with the internal flow within the hospitals and the lack of capacity in terms of community provision, in terms of care homes and domiciliary care, I don't see any practical role for the military coming in. I think when they were here for COVID, their use was in offering vaccines and in physically moving people around within the hospital campus, and that's not what we need for this. So I don't see that as an option. On the specific of White Abbey.
Yes, thanks, Minister. I suppose just before I move on to White Abbey, just to reiterate in terms of opening extra beds, the Minister's talked about the large number of additional beds that are already open. And just to delve into that detail a little moment, 351, so an extra 36 in Antrim and an extra 18 in Causeway. We're limited by the amount of physical space that there actually is, so we couldn't go beyond that. Some other trusts have been able to do more simply because they have the physical space. And as the Minister says, the staffing constraints become a real challenge, but it is easier to put up smaller numbers of beds in wards close by where you can expand the staffing resource that you have, rather than going to something completely new, as in opening up a complete new ward in White Abbey. The other thing that is important to mention is we do have some additional beds open in our community hospitals. So again, using the Northern Trust as an example, and the different community hospitals that we have. So we have increased the capacity there very significantly over the last number of years. Technically, I'm funded for 228 community beds, and last December we had 329 open, and I now have 349 open. So we're doing as much as we can to be as productive and as efficient as we possibly can, and obviously those community beds are closer to local communities, and they're really helpful in terms of when people are discharged from an acute hospital, but they require an ongoing period of assessment and rehabilitation. But what we're finding is we're now even getting delayed discharges from those community beds as well. They work well whenever you have a really vibrant and robust and sustainable domiciliary care service, and onwards into permanent placement, either in a care home or a nursing home. We have looked at White Abbey, and obviously we had the very successful Nightingale rehabilitation ward there, and we do have other services running at White Abbey. I think over the longer term, we're looking at the model around our community hospitals, and we would like to bring another ward in use on the community in the White Abbey site. We'll not be able to do that quickly. We think we can extend as far as 6 beds by the end of February, but bringing another ward into use will mean we will have to decant another service that we have put in there and find appropriate space for it, and it's also a very important service, so it's not something that we can do quickly, but it is part of the answer in terms of what we need to do in the longer term.
Tracy, more generally?
I think more generally, as Minister and Jennifer have said, there are a lot of beds up, not necessarily in places we would all want them to be. And I think, that provides a lot of the difficulties that we've been discussing. But we had, through the winter planning process, we had looked at what else could be done. We are constrained by human resource. We're constrained by space in some areas. In some other areas we might have space, but actually moving the human resource over would impact on other services to such a degree that we have to assess where those priorities are. At the minute, I think what can be done and what could have been done safely has been done. But it's a challenge day and daily. We looked at all available space. Jennifer and I would have had a number of conversations about all of the sites available, for example, to the Northern Trust. That would have been repeated over each trust. So that is the challenge. And I think to put in context what's causing this week is, we've had 2 different weeks patterns. So up to the 24th of the 12th, the winter plans were holding reasonably well in most locations. We had fewer attendances and we had less admissions than we had discharges. So the balance was in the right way. From the 25th of December for that next week, we had 773 more attendances than we would have expected to have received. So once you have that, and we clearly over a Christmas week, we wouldn't discharge as many. That's just the pattern. So that week really impacted what we had. So while we have planned and while everyone has worked really hard within all of the resources we have, that 1 week has been exceptionally difficult, and that's what you're seeing playing out, unfortunately, within our hospital stock at the moment.
Just my other question in relation to is a potential, if it's not happening already, around having a senior registrar consultant on site, to support those assessments. I think throughout that time period, is that something that is in place or can be considered?
I think it's important to say, all EDs will have senior staff on. Our direct assessment unit is also led at consultant level. I'm sure the other trusts are similar.
I think it's, well, if we can maybe explore that and find out if that's something, because if you have that, what I'm told is that if we have that level of cover, particularly between those hours of around 7 a.m. to 9 p.m, that could, if it's not already placed, be a real help in getting patients assessed. And those who can go home when they need to go home, I suppose, maybe who are in ED who don't need to be admitted, but I suppose the longer they're sitting waiting at a later stage, there's no choice but to keep them there, which is adding to the problem. My last 2 points, just very quickly, I suppose, well, you've answered one of them, Tracy, in relation to what I needed to understand is that are we seeing what was expected? And you've answered the question really that this is actually much, much higher than what was expected. So I suppose looking at, and I know we hadn't a minister in place for the winter preparedness plan last year, but as part of the planning process, were we reviewing the effectiveness of last year's plan to inform what happens this year? And as part of that, were we taking into account potential increases then as well, given, I don't know what modelling is looked at through the department. Do we look at models for what is happening in different parts of the world that are likely then to, we're going to see the same trends? Is that part of that planning process?
I can certainly talk to the winter preparedness planning, and we certainly started early. We were in March once everybody got a little bit of headspace from last winter. We took that plan. There was a series of workshops. We invited extra support from Getting It Right First Time to independently challenge us on our plans. We looked at the lessons from last year. We looked at the levers. We then had a budgetary piece coming in over the top to say, what could we do? What are we going to be able to do? And very closely, and Dr McLean might want to talk to that, we do look at the modelling from other parts of the world for flu at different periods of time. I think Joanne might want to comment more, but certainly the timing of where the peak was coming, plus our Christmas period, when those two things collide, that's really, really challenging for us. And I think that from a resilience perspective and a capacity perspective, those two things, we would never have had the available space, human resources to be able to manage that effectively. We would have seen some level of difficulty. The fact that it's as high as it is a real challenge, and not one that we probably would have had the resources to be able to manage in any case.
So in terms of flu numbers, this has been a worse flu season than we have seen since probably prior to COVID. So it's significantly worse than last year, and it's worse than the year before, so that was 22-23. So flu kind of went away. It was a really bad year, I think it was 17-18, and then flu kind of went away during COVID because we were all doing social distancing and all those things, so flu didn't really spread. It came back with a bit of a vengeance in 22-23, and we saw quite high numbers of admission. Last year we had flu, but not to the same levels. This year we've had much more flu, and flu has reached a higher peak than it did in 22-23. Luckily we haven't had as much COVID about at the same time, so most of the admissions are flu admissions. But as Tracy has said, the other thing was the peak of the flu just hit before Christmas. So the absolute biggest number of flu admissions was the week commencing the 16th. And then some trusts had their peak at Christmas week, and that coincides with a time where inevitably you get a change in how people use health services, and it's more difficult to discharge people from hospital. So I think that combination of flu on top of what is already a pressured system has resulted in particular difficulties this year, but it has been and continues to be a worse flu season than it was last year. Now, looking at the figures that we have to date, and it's difficult, it's a wee bit tricky to look at patterns of health service use and infectious diseases over the Christmas period, because how people use services changes, how people mix changes. You know, schools are closed, workplaces are closed. We do think that we have reached the peak of admissions, and we expect and hope that over the coming weeks that the numbers will come down. Now that may not be a smooth reduction, because we have things like people are back to work, back to school, so it may be a bit of a bumpy reduction, but we do think that we've reached the peak numbers and we're on our way down.
Thank you, Joanne. So I suppose just to conclude my questions, I mean, that has been helpful in getting a better understanding of where we are, why we are where we are, and I think the message that I want to come out from today is, and I know Minister you've said February we plan, and I think as a committee we probably have some actions that we would like to see in terms of working with you in relation to that, and reviewing that and monitor as we go along, so that we're not in the same situation as far as possible that we can mitigate against. But I think the message we need to get out here today to our staff who are burnt out, exhausted, but very, very resilient and powering on through here, is that we have their backs, and that patients and their families, is that everything that can be done is being done. So that's why I wanted to explore some of those kind of more specifics about things that we can and should be looking at as well, and I know other members will want to do that. The social care stuff, I think one of my colleagues is probably going to raise in relation to that, so I'm not going to go into that, but thank you for your answer so far, and I think it has been helpful to date. So I'm going to go to Linda. Thank you.
Thank you, Chair, and thank you to all of you. I have a couple of questions, just one quick one to follow on around the vaccine and the extension of that. What is the uptake, Joanne, of those who were entitled? Because the extension is great, but what are we doing to actually increase the uptake of those who were already entitled? Because they're the vulnerable, they're the ones that are most likely to be our admissions.
Yeah, so we prioritise the groups who JCVI recommend that we vaccinate, and they broadly are the people who are 65 plus, the people who are under 65 who've got underlying health conditions, healthcare workers, health and social care workers, and children from 2 years right up to year 12. They're prioritised. They're the group that we get most benefit from vaccinating. Our uptake of flu this year has been a wee bit disappointing. I have to say our numbers aren't as high as they were last year, and they're not as high as they were in that year 22-23 when flu kind of came back. Now 22-23 was our biggest success in a flu vaccine programme ever. So that we came down a bit last year and we came down a bit more this year. So if I look at the most up-to-date numbers, which I pulled off last night, these are not the final programme numbers because the programme is still going on and we're still getting data coming in. In all the 65 pluses, we've got 71.2% uptake in them. And as you go, if I showed you 75 plus, it's higher. So the older you get, the higher the uptake goes, and that's good because the people are most likely to become sick, are the older people. Care home residents, it's almost at 80%. So again, that's good. That's at a very high risk group. Care home staff, unfortunately, it's very disappointing at 6.4%. So really disappointing numbers among our care home staff. Health and social care workers overall, about 18%, just under just under 18%. The under 65s that I talked about who have got other conditions, maybe heart disease, whatever, we're not entirely confident around the denominator there, but we have vaccinated 99,000 roughly in that category, and that's probably about 40% uptake in that group is our best sort of estimation at the minute. As I say, these are provisional and figures that are being provided during the campaign. We have vaccinated almost 60,000 children in post-primary schools and over 100,000 children in primary schools, and just over 2,360 pregnant women. So they're all our groups, and it is disappointing that our numbers haven't been as high as they have been in previous years. We have done a lot to promote the vaccine sort of through social media appearances. I have been on, Minister's been on, and any support that we can get from elected representatives sort of encouraging people to come forward is great, because I do think while we do think we have reached and just past the peak, we still have a fair bit to run in this flu season.
Just to add, Linda, if I may, the vaccine hesitancy is a thing, and it's not specific to Northern Ireland.
So whenever because we meet regularly with our colleagues in England, Scotland, Wales and down south, and we talk to them, and every single one of those countries are saying the same thing as we are, just a bit less enthusiasm, about coming forward, difficult to get the uptake that we would have had in the past. So there's a lot of work that we're doing together with them to try to understand how can we improve this for future years. But we're still appealing to people. If you're in an at-risk group, please come forward. And of course now we're going to extend it, because we do have some vaccine left over, and we'll make that offer available to the 50 plus. But it was really important that we prioritised and had a good offer for people who are in those at-risk groups first.
Thank you. I don't want to dwell on that, but I think we do need to understand why, what is behind. And we do understand some of it around the vaccine hesitancy, but we need to listen to the people around why they're hesitant, and be open to listening to them, because we can't just lock down and say this is all an overhang from COVID. We have to be open to listening to people, because I do think it is a thing that should be a choice for people. It absolutely should be choice. So we need to understand, and we need to have the conversations, and open and honest conversations around that. So I want to focus really on the social care element. We know that the front doors of the hospitals are open, the back doors are bolted, shut. Nobody is leaving. The figures tell us that, and you're right, Minister, in terms of when was the last time any of us were in an ED. I was in one last year. I certainly wouldn't visit one this year, because I don't think they'd want me. I think it's right that you're there. I think you need to show leadership, but I don't think they would want us all traipsing through their EDs. Certainly not any. I don't think at this particular time it would be of any help to them. But the one thing that they did say to me in Craigavon ED was, please do not extend our ED. Please do not add beds into our ED. This is not what we need. The money needs to be invested in getting people out through the door. And when I was in that ED, there were 68 people on beds in Craigavon ED and 62 people ready to be medically discharged, and of those, 3 were being discharged. So I don't think there's been any change from last year to this year, and that's the big concern. So I get where you're coming from in terms of money. We can have all those conversations and the need for additional money, but we all know the money that can be saved by not having people staying in hospital. We know how much it costs to have somebody in a hospital bed or at home with a domiciliary care package. So it's, you're right, Minister, around the demand, but it's where we meet the demand. Where are we meeting the demand? We're meeting it in hospital beds. We're keeping people in hospital beds. We're making them sicker. We know that. And then they need higher level of care package. So you have somebody coming in who doesn't have a care package at all, and they're leaving needing somebody 4 times a day. 2 people maybe 4 times a day. That's just not a sustainable model. We need to absolutely turn this thing on its head. Jennifer, you'll be well aware, you've been in front of this committee. All of the trusts have been in front of this committee. The Minister has, all of the officials have. We know where the money needs to be invested. So let's take the money that's been invested in the additional beds all the time. I know this can't be done overnight, but we have to start addressing the domiciliary care. We need to pay people properly, and you've said you're going to do that, and I really appreciate that, because I know that the people out there on the ground who are doing the work need it badly. but we need to pay our domiciliary care workers in the rural areas their travel expenses. Asking people to go out on a normal day on some of those roads is horrific, but asking them to go out today, tomorrow, yesterday is absolutely, it's unimaginable that you're asking people to go out for the money they're being asked, but they're doing it, and they're doing it with a heart in hand, and their neighbours are going out and clearing roads for them to be able to do it. All of that good stuff's happening. People have goodwill, but we are going to break their goodwill. We're going to break their goodwill by not paying them, by not looking after them. So let's reinvest. It's not about always looking for additional money. You need it. I get that. We're supporting that. We don't need to have that conversation. But we do need to reinvest what is being spent badly, really badly. I'm going to let you answer that. I have one other question, but I'm going to let you come back on that one first.
One of the points you made was a point that was made to me an hour and a half ago at the ED at the Ulster, which is it's big enough. They don't need a bigger emergency department. But what they do need is flow. So this morning they had 76 DTA's decisions to admit and no beds for them. And 35, I think it's 35 cubicles. So it was more than double their capacity to safely and comfortably hold people who are waiting for an acute bed upstairs. So, I think that my ambition, which is a longer term thing, it can't be done in weeks or months, is that if you need to access healthcare, you should get it at home, if at all possible. And if not at home, as close to home as possible. So we're talking about primary care, we're talking about community care. The second worst option is having to visit an acute, and the worst option is visiting an acute and having to stay over. Nobody wants to do that. So the direction of travel, to my mind, is very clear, but it's how you achieve it. Because we're struggling to maintain the service within the current resources and budgets. But if you're going to transform and reform, you need resource and you need budget. And it's how we find that and release it from the current system. And let's not lose sight of the fact that while we are rightly focused on these winter pressures and the problems in the EDs at this moment, I'm still well short of delivering pay parity. And if that had not, if industrial action had been voted on when the threat was there of that vote, we could have nurses and others on strike, taking industrial action at this time. Imagine what that would do to the winter pressures and our ability to handle them. So I'm very much in tune with what you're saying. I do want to pay more. I'm talking about trying to find £50 million to give social workers, social care, the real living wage, which hopefully will make it more attractive, will attract more people in, will retain more people. And this has to be where we go and get the emphasis off our acute hospitals and onto care in the community.
Anybody else want to come back on that? No? Okay.
I'm happy just to add to that, Linda, and I would echo everything that the Minister had said. I really welcome the opportunity to have this conversation. I think everybody here knows the answers to this are predominantly not in the hospital. It's not to say that there aren't more things that we can do. We should always be looking at how we improve our services. But we know there's been historic and significant underinvestment in the community over many, many years, not just here but elsewhere. I think the real living wage is an important part of that. But we also have to look at how our population has changed over the last number of years. I've been reflecting, I've been in the Northern Trust now for 7 years, and in that 7 years the population has changed quite dramatically. So the growth of the population is 2%, but within that the growth of the number of over 75-year-olds is 19%, which is a fantastic thing. Lots of us have grandparents and great-grandparents now around for a lot longer. But whenever you think of all of the people that we know who are over the age of 75, some of them will be in rude health, which is fantastic, but many will fall into that frail elderly category. So you can't have that level of growth in the population without appreciating that, yes, we're going to have some difficulties in that. We work closely with our colleagues in the independent sector, and they do a fantastic job. They struggle at times in terms of staffing as well. And it is important to say in terms of that flow out, whenever we think about care homes and particularly nursing homes, we know that there is work to do in that sector. There are beds available currently, and some of you will have heard that on the media, What we're struggling with now are the enhanced needs of individuals, and then how do you place them in the right bed and how do you get them close to their families. So that's a really complicated situation, but there's certainly work to be done there. And in relation to domiciliary care, and you've mentioned some of the things around travel, so we're running a pilot within the Northern Trust area, recognising that we have a very large geographical area, recognising the rural nature, and it can be difficult to get to some of our areas. So we're contracting with a number of different providers to look at, rather than a time-based contract, looking at an outcome-based contract. What does this individual need? So rather than you're getting 15 minutes or 30 minutes, what is it that you actually need? And while it's early days, we're already seeing good outcomes in this, and that's the direction that we would like to go. So it's a pilot that we're running ourselves. I hope to then be coming to Tracy to say, here's the proof of concept. We need to do this in a different way. So I really welcome the conversation and the focus that we definitely need to put into our social care and our community services.
And if I can add to that, certainly, the outcome of the pilot we're awaiting. There are other things that are ongoing at the same time to help us use what we have most efficiently, because it is an infinite workforce that you can actually just turn on. We have to encourage people to come in to have career pathways in our domiciliary. My daughter herself works in that, so I have some personal insight. But what we have been doing from our side is also to look at the digital side. How did we help with digital in these spaces which are not necessarily part of the Encompass programme with our independent sector providers? So there are two areas coming on stream. One to do with our care homes, so that we've greater and faster visibility of vacancies, types of beds, whether that's a 7-day ability to discharge into those beds, and helping both our trust and our independent sector providers in that space. But we also have another for our domiciliary services, for our home care services, so that if packages are being turned, we can reallocate very quickly. So it's also, when we talk about this, it's not always about more and you. Often it is, but it's also about us demonstrating before we come before anyone that we are doing the best we can with the resources that we have. And there's been quite a lot of effort in a constrained budget environment to look at that. So, in that, there is ambition still within that, even when we haven't had significant resources to be able to use what we have in to best effect.
I think that was actually one of the questions that the Chair asked, was around, are we getting the best use of resource? I would appreciate if we can get updates on that, because you're not going to be able to answer all that today, but I think we do need to know what's happening going forward. Minister, can I just get it? Was there a bid for money for domiciliary care, for care packages, for social care? Was there any bid put in relation to that? Putting on the spot.
There was no specific bid put in for that in its own. What we had done was to actually prioritise it within the budget we had, and that's where the £70 million from last year that was announced previously had come from. So we would have seen that as being inescapable, and that was the first thing that we were saying. We have to be able to meet the financial demands of minimum wage at that time, and obviously we're looking ahead to the next. So it was encapsulated within the overall budget, but not separate.
The main bids were for waiting lists and were not met.
No.
Okay, no, look, I appreciate that. The only other question then I have is just to follow on also from the Church, just around the acute care at home, and it's a general point I think needs to go out there. The service in Southern Trust is brilliant, if you know about it. There is not enough link-in between primary care and the actual acute care at home together, in terms of if you contact your GP service or you're in contact with some other primary care service, ensuring that if acute care at home service is the right service for you. If you're lucky enough to know about it, somebody tells you about it, or you just happen to be lucky enough to fall into that service, but it's actually not. There isn't enough tie-in. I think that's one of the pitfalls within it. I do think that needs to be addressed, and I think that's something, maybe a conversation you could have with the Southern Trust, and making sure that there's yourself, Tracy, a good tie-in.
Is there solid evidence on that, or is it anecdotal? I mean, I'm not questioning it.
Well, I mean, I can say from my own area that it's not something that GPs very often refer into. It's usually where families have heard about it and ask for it, or contact me and I say, why have you not asked for it? So I think that would be a wee bit of a concern. I think we just need to ensure that is working well. It is an excellent service. I want to see more of it. I think it is something that we can do more of. And I mean, I agree with everything the Chair said. I don't want to take up any more time because there's a lot more.
Just on that, we're in the Daisy Hill on the 23rd for our meeting, and we're meeting with the Acute Care at Home Service as part of that, so we can maybe tease some of that out as well. Okay, thank you, Linda. Diane?
Thank you, Chair, and thank you, Minister and team, for coming today at short notice. I think that we are all in this room, I don't know how to express it, vexed and worried about the situation in our hospitals and in our EDs. And I think everybody shares your plight in relation to how to manage a very, very difficult situation. We understand that. But there's a number of things that I still think that we need to explore and understand. And we've talked quite a bit about the flow of patients through the hospital today. And I put down questions on this in March of last year. And in March of last year, I was told, and this is the question, or the answer, sorry, that we had 628 patients in Northern Ireland that were medically fit for discharge but couldn't be discharged. I asked virtually the same question in July so that I could understand the difference between a time when we might be experiencing winter pressures and a time when we wouldn't be experiencing winter pressures. And the answer came back from the department that there were 512 people in Northern Ireland who were medically fit to discharge but couldn't be discharged. And this answer did not include figures from the Western Trust, who could not provide them at the time for whatever reason. So this is an issue that we know about. It isn't new. We know about. I was with Jennifer at the end of November, and where we discussed that on that particular day, about a quarter of all beds in Antrim Area Hospital were occupied with people who were fit to be discharged. So we keep on seeing the problem, but I'm interested in what we've done about the problem. Now, the answer that I got back in March indicated and talked about the 70 million of support packages for social care providers and hospices, which was meant to make the sector more financially stable and viable. It also talked about the performance management of SPPG and trusts. And I think we'd like to understand why the situation just continues as it is, despite the promises and despite, 70 million, I'm presuming, was a substantial amount of money to be given at that period of time. Do we have figures for how many additional care packages that provided, how many respite beds, etc., etc.? I still don't think, I think we can talk a lot about flow through the hospital, but it's not a new problem that has arisen in January 2025. We've had it for a considerable period of time, and we continue to have really high levels at all times throughout the year of this particular problem, and I think it is an issue that needs addressed. So that's the sort of first area that I think I would like to explore. And I suppose the second is, and I'm really glad to hear, Minister, you talk about a living wage for social care workers. Domiciliary care workers they do an enormous, they play an enormous role within communities, but they have been the poor relation in terms of pay, in terms of conditions, in terms of paying them for their transport, etc. So I'm really glad, and I think there's no one in this committee that won't support you in trying to get that through. I think that's a really good issue. But it's a long-term issue and won't help us now. And I think that people watching this committee will be disappointed that we're being told we kind of have to chug along as we are now in the hope that we'll get something better. And I think people will be disappointed by that. I'm just expressing a view as I see it. So I think the issue for me is about that hospital flow. It's about improving domiciliary care services. It's about creating extra beds in our communities. And I do warn, and I hear a lot in the news, and I hear Jennifer talk about White Abbey. There is life outside of Greater Belfast. And, you know, as an MLA representing an area that is not Greater Belfast, you know, we need to see that investment across Northern Ireland. Can I also just finish this sort of segment is just to say there are some really brilliant things happening in healthcare. They're just not consistent and they're not on a large enough scale. So the hospital at home service in the Southern Trust, my area, is a really good service. But it does depend on what care family can provide that help you to maintain that, you know, as well. And that's it's important that we get that enhanced care for people who are availing of that service. And the direct assessment units, I have personal experience of the direct assessment unit in Daisy Hill. It was fantastic. From 3 o'clock seeing a GP to 4:30 being treated in a direct assessment unit. It's amazing. It is a really, really good service if we can only expand that. But they don't open, their hours aren't terribly long. So you have to be sick within a certain period of time. And I think if we can expand that, then we can surely help to ease more of the pressures in terms of EDs. Sorry, over to you, Minister.
Well, I'm very glad that you're acknowledging that every day the Health and Social Care Service delivers thousands and thousands of really positive results.
Yes, it does.
And it's great. I'll go through in turn some of the other issues you raised. I'm not sure how disappointed people are in terms of chugging along, because I think people understand very well that MLAs voted for an entirely inadequate health budget. And you're now seeing part of the consequence of supporting that budget. You point out the discharges only dropped by 116 between March and July. And in fact, if we had the accurate figures for the Western, maybe they didn't drop at all. Well, I think that just confirms what I said in my opening remarks. The pressures are not just winter pressures, the pressures are 365 days a year. And to change that, you're going to have to invest. You're going to have to increase resource, you're going to have to increase budget, you're going to have to increase the workforce. Otherwise, we are going to chug along. The 70.7 million, which my predecessor Robin Swan invested, slightly surprised that there's a misunderstanding here. It wasn't for social care packages. 62.1 million was to cover the national living wage. It went to independent sector nursing homes, independent sector residential homes. It went to supported living settings, to jointly commissioned supported accommodation, to independent sector children's homes, independent sector domiciliary care. It went to self-directed support and direct payment contracts, and it went to HSE contracts in community and voluntary and hospice settings. The balance, which was 8.6 million, was allocated to domiciliary care providers to increase the provider rate to £20.01 per hour, and that was to try and stabilise the workforce and capacity with enhanced payments. So it wasn't about buying additional packages.
Okay. Could I just ask a question on the back of that, just in terms of care packages? One of the things that I find, so an elderly person goes into hospital, they have a care package, and that care package may be the most extensive that can be had, which is literally 15 minutes 4 times a day. But if they're in hospital for a certain period of time, then that care package may be removed. I think there's maybe one trust in Northern Ireland that actually guarantees that care package beyond that. Is there any way that because it's a great source of worry for families that those care packages could be removed, and then they go to the bottom of the assessment again, and it's really, really difficult to get things moving again. And is there anything that can be done to actually look at that?
And Jennifer might want to come on the back of that. That's on the protected packages
Yes.
space. And I think there's a fine line between how long you protect it to stop someone else receiving it when you've got challenges. But I know it is a source of distress to people when you're having to re-go through, but you don't go necessarily to the bottom of the queue again.
Do you have figures, Tracy,
I
for
don't
the
have
exact
figures
amount of time that you're allowed
can't-
to protect that package?
I can't
Because
give
it's
you them
very,
today.
it's a relatively short period of time.
I can't give you them today, but I will
That'd
provide
be
the committee
helpful.
with that information. Actually, may be useful with some of the other elements that you want, particularly around domiciliary care. But it is that judgment call, and trusts are always trying to make the best use of whatever they have in the resources. But I know there are protected. I think it's in 2, but I will have that confirmed rather than speculate when I don't have the
I
information.
do think that that is an issue. It is an issue for families because those care packages are very precious. They're very hard fought, and so on. And it is a huge issue for families. Can I ask, in terms of the issues of patient flow, and you may do this, and I may just have missed it on the website. Do you actually publish figures on delayed discharges on a regular basis?
I can answer that. We don't, but we are going to. So because we've changed to the Encompass system and we've had the digital coming on with all of our 5 trusts, it's coming from different places at different times. So what we want to do is to make it comprehensive, but our trusts work with the Regional Coordination Centre and provide that information every single day. So we'll be working with trusts to be able to put that on because, again, it's information that we're happy to, that people see, and we'll put it on the HSC, where the same place where you get all of the waiting times and all of the other information, and we'll try and have that running maybe over the course of next week so that it's publicly available.
Has there any work been done in order to assess the amount of money that could be saved if we were able to get people back home into their own home with an appropriate care package as opposed to keeping them in hospital? Has there been significant work done in that? Because I do think that's key to progressing the issue around patient flow.
It'll have been done in pockets. It's not done as a whole composite. We are looking obviously at the demand capacity piece for our urgent care services, but when we're looking at different pockets of investment, absolutely we do look at the differences, but is it done? Because it's constantly moving. So at the minute we may have 350 beds. Next week that might be slightly less. So it's a difficult one to absolutely peg as a regional composite, but we do look at it.
I'm not sure there is an actual saving in moving somebody from an acute bed into their home unless they're the last patient who wants that acute bed.
Exactly.
If there's another patient waiting in ED for that bed, then the costs continue.
It's the constant movement and the
But
growth in demand.
it's the movement of people out. If you constantly are holding a bed in a hospital as opposed to having a care package, it would allow more people to flow
Yes,
through
it'll
the
improve the
hospital
flow, but it
much more significantly. I think that is really important.
It will improve the flow, but it won't save money.
It's fine.
Okay.
Okay.
Thank you, Diane. Orlia?
Yes, thanks very much. And so obviously you're aware, Minister, when you were speaking about visits to the emergency departments, I actually bumped into you whenever I was in with my son. I don't think you recognised me because I hadn't slept and I was sick with worry. Yeah, and I suppose a lot of the conversation has focused on, and rightly so, the experience of older people, people with dementia, people that are very sick and elderly, going through long waits, waiting in corridors, the lights, the noise, the activity, all very traumatising. But maybe just to bring it from the perspective, even whenever I had my 2-year-old down in the emergency department 2 nights in a row, and all those wee sick babies and young children and stressed out parents and worried parents were in that same environment where it was cramped, it was noisy. When I had torn down the first night, there was no seats in the waiting room for me and the baby. And when he was admitted the next night, there was no beds. And all that was fine because all I cared about, and the same I'm sure goes for the people that are in the emergency departments and the patients at present, all you care about is getting better or getting your loved one better, and that's all the staff care about as well. But you can just see, and I could see at the start of December, at first hand the conditions that the staff were working in, the pressure that they were under, but also the pressure and the stress that the patients were under. And with all that said, as you pointed out after Diane's remarks, all of us in this committee are, the main message to any health and social care worker that's watching this or tuning in is that we fully support them. And my baby, they got my baby better, and I got him home 2 weeks later, and that is all that matters to anybody that's seeking help and care in the hospitals, that their loved one gets the treatment that they need. And there's just the doctors and nurses, brilliant, amazing angels. So it's just to say that we all feel that way, and that's what's most important. That's the reason even for the recall of this committee. It's how we can actually help and support those staff members, yourselves in the department, you as Minister. We all want the same thing, and it's to try and help ease the pressure. So just to go back to Tracy, you had mentioned in terms of any immediate measures that are in place to try and ease the pressures as they stand at the minute, that basically all that has kicked into place and that you have went round each trust area. So my first question, I'll just ask 2 quick questions. My first question is the trusts, is the leaders within each trust, and more importantly their staff that's working on the ground in the emergency departments, is our health and social care staff content that that is the case, that all of the immediate measures have been put into place, that can be put into place? Or is anyone doing a sort of watch and brief and contacting the staff on a daily basis to say, listen, is there something here we can do differently? Is there an idea that someone else might come up with tomorrow that we can put into place? I'm just conscious that there might be, ways and means of changing things in that immediate basis that might help. And then the second question is around the GPs. And again, I know this might require more money and finances, and it mightn't be as straightforward as just kicking some of this into place. But the out-of-hours services, is there anything additional can be pumped into the GP out-of-hours, where maybe, some additional doctors or nurses can be going out into the community when patients are ringing up that they're sick, to prevent them going down to the emergency departments? And then what might be a bit longer term is in terms of GPs hours, in terms of weekends and evenings. Has any of that, or could any of that be explored in the here and now, or maybe longer term, just to help with the ED pressures?
If I can take it in reverse and start with the GPs, and perhaps Jennifer might want to comment on the staff feedback. From our GP services have been delivering significantly additional hours over this winter period. Minister mentioned the additional investments that we prioritised to help in this space, both within our GPs and our pharmacies and our community pharmacies. So we normally, around in a week, 195,000 consultations from our GPs. And 56% of those are generally face-to-face. That fluctuates a little, but gives you a sense. What we've had, and the preliminary figures, but we think will be in the range of 200 to 210,000. So we have increased the weekly face-to-face and virtual consultations from our GPs. Now, that might be GPs or one of their other multidisciplinary staff, one of the nurses or paramedics or others working with our GP practices. So significant was done, and I also had evidence of significant support from my GP practice who came out and prevented a hospital admission of a family member. So they are working.
And is that, do you mind if I briefly cut in, Tracy? Sure. Is that within the sort of 9 to 5 working hours at GPs? So it is. Additionally,
and then our out-of-hours services continued. Now, they were constrained in some areas at certain points given staff availability and absence. So we did have pockets of challenge where the sheer volume and people being ill, just like the rest of us were ill at the period of time. And our urgent care centres have been working as well, which are supported with our primary care staff. So we have a lot of that working. It might not just be your GP practice working over that period, but we have the community of our primary care support in different places across that piece, but it won't necessarily be your GP practice that you would phone Monday through Friday, but it is built in other ways. So, there was planning for as much as we could reasonably ask our GP community to deliver extra. They are doing so. And we do see messages in the press, but I'm pleased to say we can see it coming, and the investment that we've made has been well received and has been delivered upon by both our GP practices and our community pharmacy colleagues, who are also supporting with sore throat, UTI and other services, which has been helpful. So again, without significant budgets, we've tried to prioritise what we can, where we can, to make the biggest impact, to again avoid admissions, and also to support independent sector providers who I have significant contact with on the ground. And the funding last year, a lot of it was about stabilisation and trying to maintain a workforce to be able to continue to deliver. And as quick as we would manage the 500 packages, there'll be 500 more behind them. So the growth in our elderly population, which Jennifer's referred, it continues. So it is a relentless focus on all of these things, and it's not a once-off resolution that we sort 500 and then we're back to where we need to be. So it's that continuum the whole way through.
So then in terms of staff feedback, and as you can imagine, I've been in ED in our wards very frequently over the last while, and thank you for also recognising that these are daily pressures. They're not just winter pressures. There's a particular exacerbation at the moment, but it is difficult every day. And interestingly, there was a meeting just yesterday. We've mentioned the Regional Coordination Centre that all trusts take part in, including the Northern Ireland Ambulance Service. And this was feedback from all trusts and from the RCC team, coming from our people on the ground. And I've heard this directly from consultants and nurses whenever I talk to them. What they talk about are, how do we keep people living in their nursing home? How do we support them to stay there when they're unwell? And that's partly the acute care at home services. And they're asking, is there more that GPs can do? I want to recognise that our GP colleagues are under huge pressure, but is there something that we can do to support them, to allow them to look after people in care homes? It's also around how we manage palliative care in a better way in the community, because people are being brought to hospital EDs, and that is not a dignified thing at the end of life. And most often, staff, even in ED, are looking down the line to the discharge and talking about what is it that we need for people with a delirium, people with dementia, and people with enhanced needs. So actually everything that they're talking about that is needed is outside of the hospital. It's all about the community. It's about supporting people to be discharged in a safe way if they've got enhanced needs, such as a risk of falls, or they're needing help with feeding. It's about a dementia placement. It is about a delirium. That's what my teams are asking for.
Thank you very much.
Danny?
Thank you, Chair. Thank you for all your answers so far. A few of the questions I was going to ask have already been asked by other members, which means we're obviously all thinking in the same direction, which is good. I want to first welcome your nudges to the levers that you have announced here today. Certainly the expansion of the vaccination programme to over 50s, I think is a very, very good idea, and that will help to protect people going forward. We all know that vaccination is the best way to protect people from flu, from COVID, and I would encourage everybody to get vaccinated as much as they can. The other nudge, the extension to the sore throat test and treat scheme, I think is very wise. I know there was some apprehension that was going to be ended at the end of January, so hearing that's going to be extended is obviously a very good thing. Our community pharmacies do a great job, and seeing that extended, that will help to reduce pressure as well, so very good. And I also welcome your commitment to paying the real living wage for our domiciliary care workers. I think that would be a fantastic step forward. Just to go back to your winter preparedness plan that you announced to yourselves in November. Now, you stated that planning had started in March. So I'm just curious as to why it was not published earlier in the summertime. Would that not have given it more time to bed in, to be established, and to be understood a bit better? Also keen to know whether or not this plan was co-designed with healthcare professionals here in Northern Ireland, people like the RCN and other healthcare organisations. And just, I know you've talked about your blank page for next year. When are we planning to have that published for next year? Would you look at an earlier publication date?
So yes, we did start in March for the plan, and that seems like a reasonable time when you allow people to actually get through the pressures of winter. You're into February, March before you'd start. Absolutely, we worked with trust colleagues from a number of different areas, and we would have worked with our primary care colleagues as well to take that through. And we brought GIRFT in to oversee and challenge and be that critical friend to us to make sure that we had covered all that we should and could cover. So why it wasn't published at that time, a very good question, because it was a constant review, look at it at different levels. So we looked at it regionally, then we had GIRFT look at it, then we looked at it locally. Then we went back and let our regional control centre colleagues who would work with Trust challenged it then down into granular level. That constantly went on all the way up through to, I think, the week before Christmas, Jennifer might remember. But that was continuous. So we don't just plan and leave it, because then we'll have our public health information on the flu and the likelihood coming through. So we're constantly looking at it. So when we publish it, that's one point, and we can provide that. But just to reassure, this is not something we do and leave on a shelf. This has to be dynamic, and it has to be constantly reviewed. Now, the levers, we don't have all the levers we would wish, and we don't have all the resources, both financial or human, that we need, and space capacity wise to do everything we'd want. So it is within a context of what is available to us, but that's why it's not published earlier. We went through a very significant programme. Minister's plan for this year will be even more comprehensive with other stakeholders, but we would have had service users and others with us in the programme this year, and we will reach out wide. We're very open to that, to reach out as wide as we can, to have the widest possible voice into the place.
I would plan to start this year in either late February or early March latest. I can't tell you how long it will take, because I don't know how many people are going to try and populate that blank page, and how how difficult it is, and how much research we have to go to test ideas. But once we've done it, I see no reason not to publish it right away, and then re-emphasise it perhaps nearer to November or December of this year. I think there are two ways of doing this in terms of co-design. One is to write it up and then say to stakeholders, what do you think? Which is not co-design in my view. The other is to take a blank page and to say to stakeholders, how are we going to fill this in? And that is my idea of co-design. So I want to be in a room like this with somebody from the Royal College of Nursing, and then somebody from the Royal College of Emergency Medicine, with a consultant from an ED department, with the director of unscheduled care from the ED department, with the chief executive, with whoever we need in the room, to say, how can we design levers that makes this significantly better come the winter of 2025. I don't think we'll crack it, but I think it's very important that we're seen to make a significant and measurable and a noticeable difference, not least for the morale of the staff, because I think we all acknowledge they're absolutely burnt out. And the problem is they don't see light at the end of the tunnel. They don't see hope, and we've got to inject hope.
You mentioned the Royal Colleges there. Were the Royal Colleges involved in this year's winter planning?
I would need to confirm that for you. I wouldn't want to say yes or no. I wasn't involved personally, so I wouldn't want to say at this point, but I'll get it confirmed.
I am not aware.
No problem, thank you. Moving on to building on from a question the Chair asked, just about making best use of resources, the available resources. Now, obviously, nursing agencies and things like that are something that we generally try to play down. Are you aware of any resources that are available that aren't being made best use of or not being flexed yet? Is there anything that we could tap into to bring staff in?
I am not aware of any option that has been brought forward that we aren't already trying, and certainly we've had a number of conversations that if there was a good idea and there was a financial impact to it, that we'd be absolutely receiving and looking at it and best, but that has to be seen in the context. We're not yet in a financial balance to enable the pay parity, so we're again, it's like a scale the whole time, but there is nothing come towards myself and SPPG at this point that says if only you could provide funding for, and we listen. I think my comment to Jennifer and fellow chief executives, we look at any and all options if they are there and would make a difference quickly. We would absolutely be talking about them in a positive light, but I'm not aware of any.
And I think we have to give credit to Jennifer and her colleagues, because they've driven over 200 million of savings in this financial year, which is absolutely unprecedented. And I think on a kind of pro rata basis, I'm not aware of any other government department which has delivered savings on that scale. And she and her colleagues are going to be asked to do more the next financial year. So if there is any room in the system, we will flush it out.
Thank you, Minister. I was very encouraged to hear that you were out talking to workers on the front line and getting, their voice and hearing what they think. Can I ask you what you learned from workers on the front line and talking to workers?
Well, I think what I had confirmed was what I mentioned in the opening remarks, and that they feel a moral injury because they trained and it's not a job, it's a vocation, and they feel the hurt when they see people on chairs for 4 days in a row, when they see people deteriorating and deconditioning, sitting in ED departments. I mean, they really feel it. They take it home with them. It hurts them mentally, it hurts them psychologically. And also talking to some of the patients, by the way. Now, there was a patient and he's terminal. And he's not in a hospital bed. And we're speaking to him today. And he was just full of praise for the staff, for the nurses and the doctors, and talking about people being worse off than he is. He's dying. I mean, all healthcare is personal, and I have to take this really personally. Otherwise, I can't do it.
Thank you. I'd like to raise one other thing just about vaccinations. Now, the figures that you read out, there was a couple of them were quite shocking, as I'm sure you appreciate. Certainly the care home staff, 6.4% is a shocking figure to hear. And the other healthcare figure, I can't quite remember. Did I get that one down? 18%. Is there a particular drive at the minute to try and get those care home staff and healthcare staff vaccinated up?
So, as I said at the outset, these are interim figures, so the programme is running on. The way we count vaccinations, there are likely to be care home staff and health and social care worker staff who have been vaccinated, for example, in their GPs because they've got asthma or something like that, and they're not being properly counted against being a health and social care worker. Now, I think that is a real issue, and the uptake is likely to be a bit better than it appears, but I don't think it's as good as it needs to be. I think the care home staff figure is low, and we need to understand a bit better why it is that low. Whenever the community pharmacy vaccinating care homes, and they go in and they offer it to all the staff when they're there, so that's where we get that figure from. So it is bought to the staff and it's made accessible. I think that trusts, we want to be working with trusts next year to really explore how we can improve health and social care worker uptake. Whenever we got the best uptake that we've achieved, it was whenever we used a lot of peer vaccinators, and that we had sort of staff within each ward vaccinating. I think this is symptomatic as well of the wider pressures in the system. We just don't have as many staff to go out and perhaps deliver the vaccine in as many locations as we might have done in the past. But I think it is something that we want to work with trusts next year to really get it up, because it makes a difference if we get our health and social care workers protected, so it'll be a priority. We are, of course, still encouraging it, and trusts are doing lots, bringing it to the canteen, trying to make it accessible, making sure that night staff have access and things like that. But clearly we want to improve that. But as Minister indicated, this is being seen in other jurisdictions as well, where in particular low uptake among care workers, and there are differences between groups of staff. So medical staff, for example, tend to have a higher uptake than some other staff groups. So I think there's a lot of work that we need to do. We haven't been advertising, like paid for advertising on buses and TV and radio and things. The flu vaccine this is the second year. Last year we had advertising was 22-23 when we got our bumper on our record uptake. I think that is because of just general budget constraints across departments, that we haven't been able to afford to do that. But that's something as an agency that we will be making sort of a bid for, and saying, look, we do think that that's important to advertise it, to raise awareness. And I think, as Linda said, we really need to understand better why people aren't coming forward for vaccination. We have an ambition within the agency to develop a behavioural science team to start to understand, you know, what things can we do to make it easier for people to get their vaccine. How can we explore people's anxieties, fears and whatever. And what we have to accept as well that it is a choice. I want people to be vaccinated because it makes such a difference, and it makes such a difference to your own health and to the health of the whole population. But it is an individual choice, so we have to be able to work with people so that they make those choices.
Absolutely, and that was something I was going to move on to, that I hadn't seen a public campaign to encourage people to get vaccinated this year, and I think maybe that has impacted the vaccination rates, and I do remember the previous ones, and they were very impactful. You know, it was a reminder, and it was encouraging people to go out and do it, and whatever else. And I think certainly there is value in that. So that was because of budgetary concerns within the BHA.
My understanding is that a minister will be able to speak to this better. But my understanding is that there's as part of sort of making best use of resources across the executive, that there are limitations on paid for advertising, and this is one of the campaigns we haven't been able to run. So I think it's something that we would hope next year that we could make a case to the department and the executive to do advertising, because whenever we evaluate it, whenever we look, we run our programmes and we do evaluate them, and they do make a difference.
Was there a case made for keeping paid for advertising for vaccination?
So it is something that, as an organisation, that we have asked, can it be funded, but unfortunately it just hasn't been. Now we do lots of other things, so it's not that we don't do anything. We've mentioned that we do a lot of press releases, media interviews, social media, and I wouldn't underestimate the power of social media, and in fact the reach that elected representatives have, just making people aware that the vaccine is still available as well.
Those big mass market, your TV, radio, and
we haven't.
There's a moratorium on that, but I'm not sure that sort of advertising would impact on the 6.4%.
I don't think so. No.
I think we need to deep dive into that and get a better understanding, because it is shockingly low.
You'd mentioned vaccine hesitancy as an issue. Is there anything that you're looking at specifically about vaccine hesitancy and try to encourage people?
Well, it's trying to understand the figures.
So we are working with colleagues in other nations, as I mentioned earlier, and there was work being done to try to understand that. I think we do want within the agency to develop capability in that, so that we can really understand that and sort of have interventions that will perhaps encourage people to have uptake. Now, we're being very negative here. Over 500,000 people have had the flu vaccine.
Oh,
so I want to say that most people who are eligible have come forward and got it, so that is a good thing. We have vaccinated over 500,000 people. The season is not over, and we would like to encourage people, particularly those who are eligible at the minute, and whenever the offer extends to 50 plus, again, encourage people to come forward. Vaccinations do work. They reduce your chance of getting flu, and if you get flu, they reduce your chance of getting really sick. So do work.
Oh, absolutely, I completely agree. Thank you very much.
Thank you, Danny. Colin.
Thank you, Chair, and thank you, Minister and team, for coming along, although I'm not so sure that there's going to be anything different at the end of this meeting from there was at the start, and I think that's a reality. I think we just need to accept that. We are where we are, and I suppose I was hoping that maybe you might have been able to say things that were going to take place that would be different. Those levers, as you referenced, that would be pulled. But again, hearing that there's just very limited scope. This meeting has been called in response to the fact that over the last 2 weeks there has been a growing crisis, which is likely going to take 2 or 3 weeks to sort of tail down again, as has been referenced. And some of the things, such as vaccinations, is probably going to have little impact on that, because it's going to take months to get people vaccinated, or a month or so, 6 weeks to get them vaccinated. People have mentioned about taking money out of, basically saying shut down beds and move it into the community, but then there's going to be no beds for people that are sitting in ED that move along. And I suppose, Minister, you're a member of an executive, and I have to ask the question, and I ask it genuinely, I ask it as a member of the opposition. Do you feel that your executive colleagues are supporting you? And if 3 or 4 weeks ago, when you would look and could see the projections that this problem was coming, if there was more money made available to you and it was spent, would things be any different today? Would there have been any support for some people? Or are we just looking at the situation was just out of control and was just going to happen? It was like a runaway train that was just going to crash, and we can't do anything until it's crashed and pick up the pieces at the other end?
Well, I think it's well known that every executive colleague has pressures, financial pressures. They have pressures in terms of delivery. I mean, I would make the case that the pressures in health can have catastrophic impacts in terms of, can be a fatal impact on patients. So yeah, I think there's a mutual understanding of the pressures. What I have objected to, and I've done this publicly, so I'm not going to break any confidentiality in terms of the executive, is this idea that suddenly the assessed need, which was so successfully argued in terms of the block grant, going to 124%, is not being recognised. And this idea of you've got more than 50% of the block grant being some sort of reason for saying we'll just get on with it is not logical, because the assessed need is the assessed need, and if that means we need 52, 53, 54%, then that's where it is. And I think people think reform is going to save money. I think the best thing that we can happen from reform is that it slows down the pace at which extra money is required, and I'm very keen to do that. And as I said in the opening remarks, I want to drive productivity, I want to drive efficiency, but no amount of efficiency and productivity is going to close that gap between capacity and demand. I think it's very difficult for executive colleagues because they are looking at, an eye-watering amount of budget. It's going to be over £8 billion. I mean, that is an awful lot of money. And do we all understand each other's pressures as well as we should? I'm not sure that we do, and I have argued for a more collective approach, because if you take any significant subject that we're trying to improve as an executive, it's going to be very, very rare when one department can fix it. We now know all these things are interrelated. Even you take educational underachievement, healthier children do better at schools. So it's not just Paul Given's problem, it's my problem. So I think we're maturing in terms of that collective approach. But in terms of the short-term levers, it's not me saying this. I mean, I sat with the Royal College of Nursing and the Royal College of Emergency Medicine and representatives of the Trust, actually some from Jennifer's, and said, are there levers we're missing in the short term? And basically the answer was no.
And I accept that's what's been said, and I think if this was the Scottish Government or if this was the Welsh Government in the other devolved regions, if there was a significant problem with the health service, those cabinets would get together to try and find some sort of resolution. They would try to find collectively across all of the government the levers that they could pull. So can I ask you, has there been, or are you aware, is there due to be an executive meeting of all of our ministers to consider the peril that there is for the health of our population? Is that been planned to discuss that specific issue in the coming days?
Yes. It's not. There will be an executive meeting in the coming days, and I will raise this issue at some point during that meeting. The meeting will not be called about this issue, but I will raise that issue.
It's just an executive meeting as normal that you'll be at, but you will raise this issue. Because I hope so, because I hope that we can find from the entire executive what its response to this crisis, and I'm not calling it a crisis, other people are calling it a crisis, and I hope that you can raise that issue, Minister, and I hope that there is a full executive response to this, because it's for the health of our population and it's a crisis in our hospitals.
Yeah, and the other thing that I've said, I think I've said it publicly so I can say it again, is if you have 9 priorities in your draft programme for government, and one is waiting lists, and yet the narrative within the document says it will get worse before it gets better, and when all bids for ring-fence money to address waiting lists are rejected, then we're not exactly being consistent, or indeed particularly honest with people by saying it's a priority, but we're not spending money on it.
I wish you well at that meeting and look forward to the outcome from all ministers of parties all represented here today to see what the outcome of that will be.
Thank you.
Good luck.
You can, Alan Robinson, online there. Right. That's to you now, Alan.
Okay, thanks, Chair, and thanks, Minister, and thanks to the team today for making yourselves available. Minister, I don't want to say this as a negative, but I just want to understand why, given, and it is very welcome that you said today that the over 50s would be included now in a flu vaccine rollout. Can I ask why, as part of the winter preparedness plan, that wasn't done then, and why is it being done now rather than then? Some might say that it's a bit reactionary rather than being proactive. And I don't say that as a criticism, please don't, because you know me and I've been very honest with you, Minister.
Yep.
It's not my style. I just want to understand why it wasn't done in advance of this crisis, as Colin calls it.
So the answer is relatively simple, I believe, Alan. We tend to follow JCVI advice. So the under 50s were not part of the JCVI advice. What we focused on initially was the vulnerable, the elderly, and health and social care workers. As you've heard, the uptake in some areas has been a lot less than we would have liked, and therefore we have spare vaccines. And I don't want them to go to waste, and so we're going to use them by extending beyond the JCVI advice and offer them to this new group of people, the 50 to 64-year-olds. But we didn't have that capacity while we were targeting the elderly, the vulnerable, and the health workers.
That's fair enough, and I appreciate that response, Minister. Can I just, and again, I don't want to be too negative, but I want to talk about some of the positives, because it has been a bit of a negative meeting and a negative run-up to the meeting. You know, I had a couple of family members, very close relatives, who picked up that respiratory virus that's doing the rounds at the minute, and two of them were very, very unwell. And one of them, both of them are in the Western Trust. One of them received the hospital at home care. And I have to say, it was absolutely wonderful. Two nurses, one in the morning, one at night. And it is still, those nurses are still attending to that relative. And that has kept that relative of mine's out of hospital. It has broken one element of the flu chain. And I'm a little bit disappointed that, you know, you're telling us that there is no ability or no capacity to try to ramp or expand that service, given that, you know, we're being consistently told that how there are so many people who are receiving undignified care. There are people, you know, there is so much constraints on space within hospitals. But here is a service that would stop people having undignified care. It would improve a bit of space and a bit of capacity within hospitals. You know, and that's why I can't get my head around this. Why that can't be expanded? Why that can't be enhanced? And why examples that I've given you today, that we could see more examples of people who otherwise potentially would have been in hospital that were not in hospital, and they're cared for at home in their own, and we're very happy to be so, because I am convinced that that relative, had they not have received that hospital care home or hospital at home care, they would have been in hospital, and they already had underlying issues. You know, when they were very fearful of the potential of going into hospital as well. So not only psychologically they were helped, but physically they were helped as well. And I have to say, I'm very, very grateful to the Western Trust and the GP service in the Limavady area that provided that service. And I'm convinced that potentially they could have saved that person's life.
Well, if you want to expand that workforce, and I would love to, you need the money to do it. And the money doesn't exist. I will continue during the entire course of my tenure as Minister of Health to try and find that from within existing budgets and existing resources. But as I said earlier, I mean, Jennifer and colleagues have done amazing work in terms of over £200 million worth of savings. Now, those weren't £200 million worth of savings so that we could expand services. That was so that we could contract services to live within budget. And I have to say, you know, if you voted for the budget, which I warned and Robin Swan warned was entirely inadequate in terms of healthcare provision, then there are consequences to that, and you've just defined one of those consequences.
Okay.
Thank you, Alan. Is that you? Yeah. Okay. Nuala?
Thank you. We'll just jump straight in to questions. I have some supplementaries following on the other members' questions. Before I ask the question, if we could just go over again the number of those awaiting discharges, those awaiting discharge, medically fit for discharge, and those awaiting beds currently. Can we just have those again?
Certainly can.
Discharge yesterday was 516
Yep.
total.
And those awaiting beds?
Decisions to admit as of 8 a.m. this morning was 423 decisions to admit. Now, obviously, that will have fluctuated throughout the day.
Okay, it's just the reason why I ask is because in answer to Diane's question around getting those discharged and using the beds, you were talking about, we'll not save money, those beds will be used anyway. I think that was a bit, kind of the transparency wasn't really exactly there, and I know that Dan didn't appreciate the answer there, and I don't think that we're getting the complete transparency in those answers, because not all of the beds, if those that can be discharged is greater than those who are waiting beds, I just want to delve into that a bit more. Or have we been provided with the wrong information?
No.
Because I think there needs to be a bit of transparency here in the way in which we are delivering health. So can we just get that? Because I don't want to be wrong in asking the questions and be unfair.
I did say if the patient who was being discharged was the last patient to use that bed, then you could have a saving. So I don't see where the lack of transparency comes.
Well, if the beds that need to be occupied, those awaiting beds are 423, those awaiting discharged are 516, then there is a way in which we can use the money differently. That will it actually provide savings? And I'm talking about community care in the form of domiciliary care. Yes, that's money that will be used for that, but it's still there has to be something done differently. And if we are having those in hospital far outweighing those in need of beds, then we have to be honest there that there is a difference that could be made. I'm not saying it's a massive difference, but I think we also have to be fair on that too.
And I think if I can add to that, that's a challenge, because with those numbers that we were talking about, there's still a large number of people who are in ED who will still have to sweep through. So at any point in time, you see a number and you think it all adds and it works out well. If it were as easy as that would be what we would be doing. The difficulty then is for the beds that a lot of our hospitals have put up are additional within wards that they already have staffed. So the marginal cost, not to get too accountancy technical in that, will not be as great in the bed that you would have put there in the first place. So it's a marginal cost additionality. And the cost of some of the complex packages that we need can be as expensive, if not more. The growth in the elderly population means this continues to grow. So once you solve one part of it, it comes round in a cycle. So the 500 people today that we would need to move, there'll be another 500 tomorrow, and another, and it takes a long time to do. So that's it. So there can be pockets of savings, as I was saying at the time, for some elements of it, but it's just not as binary as that could be moved to another. It is much more challenging.
And I absolutely appreciate that. And as you said, marginal cost and then the complex needs of looking at home. Yeah. So then perhaps if we change it from looking at cost to better patient outcome, and a person who's looked after in their own home or in the rehabilitation facility, step down from hospital, whether that's in a nursing home or not, they have better patient outcomes. So if we look at it from that way, last spring we were developing this plan. I mean, it's not news or it's not breaking news regarding delayed discharge. We knew it was happening. So what exactly was done to increase those, whether it's domiciliary care packages or the beds available in those nursing care providers? I know I don't want to use the word nursing homes, but some of them are private independent providers. There's very, very few trust step down facilities available. So what was done between spring and winter of last year to increase that, to allow that patient flow?
I think it might be useful, along with some of the other questions, to get a fuller response, but because I don't have all those figures in front for what I'm about to go through. So in that period, there was a number of initiatives, early review teams, to ensure that we could use every hour that we have in our domiciliary provision as best we can. There was a stabilisation package from within the 70 million and the increased amount of money to give to domiciliary workers in the independent sector to ensure that we could stabilise the workforce, or indeed our hope was that we would grow that workforce. So there's a lot going on within that space to ensure that we all could maximise with the resources that we had available, both the human resources that the independent sector had and the financial resources that we had in that space. And I think with a number of the questions, it might be good to give committee a fuller response on some of that detail.
I think that would be good, because the Minister did just say that the 70 million 62.1 was not for exactly for, not that he didn't say it wasn't for better patient outcomes, but it was not for an increase in patient provision.
Two things. One was the national minimum wage for the vast majority, and 8.6 million was to increase our independent sector domiciliary care to pay significantly above the national minimum wage. And that was to stabilise, and there was an expectation that potentially if we're putting more wages in, the expectation is that you get more capacity. And
did we get that more capacity?
And I need to get the answers for you.
It would be helpful if we did get those. If we are looking at this blank sheet of paper, you know, what we do in the next year, it'd be helpful to see if what we did last year actually made you know, a bit of difference, because it sounds like it just didn't, you know, sitting here today. And I'm not saying that the people, whether the front line or management, aren't trying to make a difference, but it's, if it didn't, how do we value it and change it? And I appreciate it might take time to get those.
Sorry, speaking over you, I didn't mean to.
No,
it's about the significance of how much, because in the same period when we talk about care homes, we have lost provision in our care home stock across a number of our locales, and we were losing capacity within our home care sector, our domiciliary provision. So, you know, if we didn't stabilise and if we didn't make that better, we'd be sitting in a worse position now. And if all we had was to stabilise, that's the opportunity that we took to do that, and to be more productive in the utilisation of those hours during the course of the year. So, you know, it is a challenging dynamic with the other market forces.
It is, and actually raises the other issue of those care home providers. And, you know, we at the committee hear a lot of reports, both at meetings, informal and externally, regarding RQIA reports between different care homes across Northern Ireland, that, you know, lots of families are shocked to read. And is it any wonder then that when people are fit for discharge, that families don't want to accept putting them into, whether it's the furthest out care home or the nearest? So that needs to be something that we actually examine too, as to what can we do better in that space. And the other issue to just pick up on was regarding the Northern Trust pilot scheme around this social care element. Whenever your predecessor was in the Assembly chamber last year answering an Assembly motion on social care, we talked a lot about the Social Care Collaborative Forum, but these pilot ideas aren't new. They were provided and they were discussed by the Social Care Collaborative Forum for years regarding all of these different initiatives. So I just don't know why it's taken so long, and I'm glad that it's actually getting off the ground for a pilot to actually start now. It wasn't news. It's something that your predecessor had mentioned. We talked about moving away from the 15-minute allocation time that is based on need. So what has happened, or what has been improved or changed on the winter preparedness for that element, and whether you've actually fed back and into and with members of the forum to actually get their assessment, because as well we need to recognise the community and voluntary sectors work that they do, particularly around the element of discharge, but also those who provide help and care, which are seen as outside of healthcare, but they massively help the healthcare system.
I think those are all really important points, Nuala, and I think that's why in terms of the winter plan next year, the Minister's right about the blank page and all of the different elements across health and social care sector that need to be involved in that. I think you're making good points in relation to how we're currently spending our money and where we're currently spending our money. It doesn't mean that it's easy to be released quickly. So you're talking there about the delayed discharges, but also then about the number of decisions to admit that we have. And on the face of it, that looks like that should be easy and straightforward. But it's also in the context of the 350 additional beds that we have up right across the system that we're not funded for. We've had to pop up those beds. And we're able to do it largely because we're adding an extra bed or two into every ward, and we're stretching the staffing, which is not on in some areas. Yes, absolutely, not in Antrim because we wouldn't have the physical space to do that. The other thing that we have had to do is because we know that our emergency departments are so busy, we have to overstaff over the weeks of winter. So we deliberately roster more. Again, the Minister mentioned the savings that we made. So we deliberately carve out an element of funding every year in the tune of about 3.5 to 4 million so that I can put up these additional beds, so that we can roster on additional staff into ED. That's not recurrent money that I could give to something else, and that's one of the biggest challenges about how we start to shift. But there is something in here about bridging funding to allow reform and change to take place, because we know we could do this in a better way.
And I agree with that absolutely. I appreciate the Minister, the position that you're in. It is your department, and you must stand up, speak for your department. But in terms of the consequences of the current budget, I think it's a bit unfair to say that it is a consequence of the current budget when actually it's years. It's consequences of years in the way in which we have run the health service, and it's something that needs to change, not just for the next upcoming winter preparedness, and we do know that. I also want to ask questions around the Phone First. We have heard the 160,000 people use the Phone First system. We have been lobbied, and people have been in contact with us as MLAs that may not be the kind of silver bullet option of the best lever in taking pressure off the ED, because the feeling on the ground is that actually a lot of those people, when they are assessed, they don't go to the usual ED. They are assessed anyway to minor injuries. So I just want to ask if there's going to be an evaluation of the way in which the Phone First system is utilised in each of the hospitals within trusts, but also the cost at which it is to employ the running of that Phone First initiative versus the actual using the money in the first instance for more resources for those to be assessed at the point, because we have experiences with constituents, with doctors, nurses telling us appointments are given over the phone, but in reality that doesn't matter because you're assessed from the beginning once you arrive at a lot of the hospitals. So what is it actually doing? So are we able to get that valuation? And I know we're running over time.
So before Tracy comes in, I mean, Phone First is not a silver bullet. There is no silver bullet. What I would like to see in 2025 is a more consistent regional Phone First system, because I think it is to some extent different depending on which trust you're talking about. And I do like the idea of regional services where we find where best practice is and make it common practice across all the trusts. Sorry, Tracy.
And supported by that, I am co-chair of the Urgent Emergency Care Board since I took up this post, and that conversation has been held, and that is representatives from emergency departments, from medics, from primary care and others, service users, and these conversations are being had. So the 111 service, not the Phone First, so actually looking at it as a 111 service that you see in other jurisdictions. We have had a number of visits to look to see how that has worked, and again it has to look to see how do we make that different in the future, how do we make it regional, how do we make it more effective to some of the points that you have made. So all of that assessment is ongoing at the moment, and there's a lot of work behind that to consider and develop what might be end up with a business case at the end of that process to change what we have now into a fully functioning 111 service. But we have to weigh it up against other priorities. So that's one of the choices that we would have to make at the point in time when we finish the assessment. But it's actively under consideration, and certainly one of the key planks that, for example, colleagues from NHS England who have been with us said, this is, if you do it in the right way, this will be really helpful to you. But again, we need to look at the investment, how we bring it in, when we could bring it in. But that's absolutely under active consideration.
Thank you. I I appreciate the answers, and we know we are running out of time, so I'm going to move just to my last quick question. I like to ask more, but we can't. Is regarding the modelling for the predictions for the those expected to attend in A&E, but also the admissions. Why did the modelling fail, and what has happened? You know, in terms of those who are being admitted, I assume in majority for flus. We understand it is actually under 65s are an issue. It's not those, whilst those delayed discharge over 65s, actually the admissions we're looking at under 65s. So why did the modelling fail, and what has happened that we are seeing this spike?
So I think the modelling referred to by Tracy isn't actually infectious disease modelling that we would have been used to during COVID. There were sort of projections that were made, and Tracy can talk to this better than I have. They're not public health type modelling. They are projections that were made based on past ED attendances and things like that. So it wasn't modelling in the sense that we think of modelling. So
we
and
not
I think,
do that, is it?
So we do actually have capability now to model. Modelling for, remember, flu is only one of the reasons that people are going to hospital at the minute. So we do have capability to model now. That was something that came into the agency sort of during and as a result of COVID. So it was, I guess, a positive legacy of COVID. Modelling flu is extremely difficult. So we do have a model in place which we use, and we're testing it with colleagues across the UK. UKHSA, who are the main kind of leaders in this space, they are sort of still working on their modelling and their flu modelling and testing it. So it's not the same as the modelling we would have used during COVID. The figures that Tracy's referring to are projections that were based on past attendances rather than kind of infectious disease modelling, which I think that you're maybe referring to. But I think we need to remember as well, I think Tracy said that there are 288, I think, patients in hospital with flu. The vast majority of patients in our hospital are in with other things, and it's the flu on top of all the other things.
We need to do both.
Yeah.
And will that change then going forward? Will we be doing both?
So I think that we know that flu comes every winter. What we don't know is, I guess, the size of the flu wave, and that's very difficult to predict because flu changes from year to year. You know, it's a different virus. We're not sure just how well the vaccine will match the virus, and that's why it's trickier. But the thing that we do know is that we will get flu every winter, and chances are it will coincide with the Christmas period whenever services are just a bit different. So we do know that, and I think there has been a lot of discussion around what we can do around admissions and managing discharges and things better. But I've been sitting here looking at the orange circle behind the chair, and it says prevention is better than cure. And I think whenever we're thinking about like what do we do differently next year, we as a group of people in the health service and as a society need to be thinking about prevention. And I know the Minister has this as one of his top things, but I'm thinking of that. I'm thinking about smoking. Biggest cause of death and illness in our community, preventable cause of death, but there are other things that we can do as well. So we have all that public health type prevention, but we also, how do we manage people who maybe are diagnosed with heart failure? How can we manage them optimally so they don't end up having to come in? So it's that whole suite of things. So it's a really quite a complicated thing, but because I've been looking at that, I'm thinking, you know, I'm quite excited about looking forward. What do we do in the future, and how do we bring prevention into that and thinking in a different way that's not just about our hospitals and it's not just about managing sick people, it's how we stop people getting sick.
Alan Chambers.
Thanks very much. Minister, when I followed the comments yesterday from the Secretary of State for Health, Wes Streeting, I was struck by the fact that there seems to be such more political point scoring as seen in the media here than other areas. Perhaps that's a symptom of a multi-party coalition. But does the Minister feel that our health workers and indeed the public don't really want to hear our politicians sniping from the sidelines? And can it have an adverse effect on staff morale? Turning to the point that my colleague Mrs Dodds made about the letters she's written since March 24 about the number of people waiting to be discharged and the figures not really coming down. Could the Minister maybe explain to me how far back do we need to go to find when the seeds were sown for that situation to actually develop? And the last question to Dr McLean, can she confirm it's never too late to get the flu vaccination?
Do you want to go first?
Yes, so it's not too late until the programme finishes at the end of March or the vaccine runs out. So you can still protect yourself this winter. If you haven't had your flu vaccine and you're eligible, you could still get it. It'll be available right up until either the end of March or whenever we run out of stock. And I would encourage people to come forward. It could make a difference to you.
Thank you.
In terms of your other questions, how far back do you have to go? I think we all know that the health and social care system has been underfunded for many years, and that's part of the problem. And therefore the fix isn't going to come in weeks or months. It's also going to take years. I think publicly I tend to talk about 5 to 10 years, but I think some of the things I want to achieve are actually generational. And if you talk about health inequalities, I think we all accept health can tackle about 20% of that, 40% is socio-economic, 10% is environment, and 30% is behaviour. So it's a whole executive challenge. I put that to executive colleagues. I was really encouraged by the response I got. It was a kind of by the way kind of conversation. It wasn't an in-depth, let's spend an hour talking about this. But people like Conor Murphy and Andrew Muir, who would be involved in that because they are the economy and they are the environment. We're very positive about these things. So yeah, you've got a multi-party coalition government. People are going to put out party political comments. That's just part of where we are. I don't think it's going to be particularly welcomed by health and social care staff who would like to see us working together. I get a good vibe mostly out of the executive. When we came back in February, I genuinely believed that there was a different atmosphere in this building, in that debating chamber. Probably because we all realise if it goes again, it's gone. Just forget it. I can't see it coming back. And it would be very difficult to mount a negotiation on the scale of 1998, given social media and the modern environment. So I'm going to finish up being optimistic. There are challenges here, but I'm a volunteer to try and fix those challenges. And I don't think I can achieve everything between now and May 2027. But I think we can take a lump out of it, and I'd like to do that collectively with all of you. And perhaps by we get to the end of this mandate, we'll have set a direction of travel that the next minister feels compelled to follow, because the results are beginning to show. And some of those results will take a lot of time, particularly health inequalities. But healthy living expectancy has never improved since devolution in 98, 99. Could you imagine if by May 27, we have shifted the dial, even if it's beginning to vibrate and go in the right direction? I think that would be a huge achievement, and I think it would be very encouraging for the next mandate.
Thank you.
Thank you, Minister. Before I conclude, Linda and Danny have indicated they have two small points, so we need to go very, very quickly.
I know we've all changed our diaries, Chair, but I need to be somewhere else.
Yeah, no, absolutely. Very, very quickly.
Mine's a point, not a question. I am all for regionalisation of services, absolutely 100%, but as long as the accessibility is there, and I know I've said this repeatedly, Minister, so you have it in your head, but everybody needs to be able to access the services, so don't forget about the people in the rural communities, and SWA has a lot to offer. I'm not saying everything needs to be there, but we absolutely need this is just proved, we need all the hospital space that we have.
Danny, very quickly.
Just a point as well, just the two of the main parts of your winter preparedness plan were involving GPs and community pharmacies. They're two of the sectors that we've heard in this chamber that are under extreme pressure and suffering closures. So obviously they're very, very important sectors when it comes to preparing for the winter. So just wanted to hear quickly just about what you're doing to support those two particular sectors.
There has been investment, Danny, and I think certainly in terms of GPs, the issue of indemnity was becoming really, really toxic. And I said I would get something by the end of last calendar year, and we have put a proposal out, which I hope will be acceptable in terms of fixing that. And I do understand when I say I want to shift left, and that means more community care, more GP care, more pharmacy and community pharmacy involvement. When I started saying that, I think people thought, oh, he just wants us to do more for the same. I don't. If they're going to do more, they have to be rewarded for doing more, and I get that.
Thank you, Minister. And I know we've said we have all shifted our diaries. I think this meeting has been important to the contrary that some believe that it wasn't worthwhile. I do believe it's been worthwhile for a committee. I think that we've got a really good understanding of where things are at. But I hope that the message coming out today to the public is that everything that can be done is being done. And I think that we have scope now to look at how we work, I suppose, in the here and now, but maybe some actions coming out of today's meeting that we can work through for the planning period for the next winter pressures, but the ongoing pressures. And I think I would ask the Minister if we could agree that on the other side of this winter period we could have maybe a debrief on what happened, how we dealt with it, where the gaps were, and then we can work with yourself, with colleagues, with the sector staff who have the solutions, I think, to lots of these issues. And we talked about co-design, and I think that's a critical part of it. So if we are agreeable to doing that and potentially getting some an early briefing then on next year's plan to the committee, I think that would definitely be useful, in particular, I suppose, around domiciliary care and that ongoing work. But that, as others have rightly said, those are ongoing pressures that we will be, keeping a watch and brief on as well. So,
more than happy to give you the debrief once we've analysed how we've done this winter. And in terms of the blank page, I would like the committee to be involved. And actually, the blank page isn't the blank page anymore, because I've already had one idea, which relates to something you said right at the beginning, which is, should we be trying to involve GPs in a hospital setting?
And I think part of that, and given the meetings I've had even as recent as this morning, is looking at the investment in our primary care and GPs, because they can do more, and I think in many cases can do it for a lower cost than what's happening maybe in other elements of our health service, which is a saving, but also it's better use of the really valuable resource that we have there. So,
well, thank you all for your time and for your support. And
thank
if
you,
you leave
Minister,
your bank details with the clerk, that would be
thanks, and safe
it.
home, everybody. I really do appreciate it. Thank you. Members, just to finish, in terms of our own business, I thank everybody for their participation. I think that was very useful. Our next meeting is, we have a series of informal meetings on Thursday with stakeholder groups from 11 a.m. in room 29, and then our formal committee meeting is the following Thursday, the 16th of January at 2 p.m. in room 29 as well. I know some emails have went out today as well about other engagements, part of our palliative care inquiry as well, so if members can respond. But thank you. Okay.
Committee Room 29, Sound. 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 Committee Room 29, Sound.